We'll start with a Bennett fracture. A Bennett fracture is an unstable oblique intra-articular fracture dislocation involving the first CMC joint and is located at the metacarpal base. This results in shortening and deformity. 80% of thumb fractures involve the metacarpal base, and Bennett fractures are the most common variant. Complications would include non-union, instability, and traumatic osteoarthritis. The mechanism of injury results from an axial load and a deduction force on partially flexed thumb. The proximal palmar fragment is stabilized by the strong volar oblique ligament and is held stable. The larger distal fragment is displaced dorsally and radially by traction from the abductor pollicis longus tendon. Differential diagnosis would include Rolando fracture, extra-articular metacarpal fracture, UCL ligament injury, volar plate injury. Rolando fractures are less common and more complicated and severe. They result from comminution of the larger dorsal fragment into a Y or T-shaped fracture. On an exam, there will be deformity and shortening of the thumb. X-rays will indicate dorsal radial displacement of the larger distal fragment by the APL and adduction, adduction, and supination of the shaft by the adductor pollicis. Imaging would include X-rays including the AP, lateral, obliques, and hyperpronated thumb view. Management will include placing the patient in a thumb spica splint and referral to orthopedics for closed reduction and immobilization if undisplaced. If the fracture fragment is small, then it will require percutaneous pinning. But if there's a large fragment, then can proceed to ORIF. Boxer's fracture is the next injury, and this is usually a result of an acute angulated metacarpal neck fracture, most commonly involving the fifth metacarpal. Complications can include mal and non-union of the fracture, traumatic osteoarthritis, malalignment and rotation, and avascular necrosis. The mechanism is a direct blow to a knuckle from punching a wall or hitting a person. Differential diagnosis would include other metacarpal fractures and MCPJ injuries. On physical exam, there will be a loss of prominence of the metacarpal head. There usually is a mild loss of range of motion of the MCPJ. On physical exam, we must evaluate for shortening, angulation, and malrotation. You can evaluate the cascade of fingers with flex fingers. Normal position of the fingers should converge and point to the scaphoid. You should look for loss of alignment, scissoring, and crossing of the fingers. X-rays will indicate neck angulation, and cast immobilization is performed if the fracture is stable with no rotation deformity and acceptable angulation and shortening. Acceptable angulation varies depending on the digit, and there is less acceptable deviation as you proceed from the fifth digit to the second digit. Slide 17 provides acceptable angulation starting at 40 degrees in the fifth digit and proceeding to 10 degrees in the second digit. Referral to orthopedics or a hand surgeon is preferred if there's persistent angulation, scissoring, or shortening. Fractures of the second and third digit often require open reduction, internal fixation, or pinning to ensure proper alignment, rotation, and angulation. The ninth condition is tuft injuries or fractures. These are fractures of the most distal portion of the distal phalanx They're often comminuted but considered stable. There's a high incidence of associated soft tissue injuries to the nail or nail bed. The mechanism is often a crush or shear injury. Differential would include shaft and intra-articular fractures, soft tissue injuries and lacerations to the nail bed, and subungual hematoma. On exam, you'll see swelling, discoloration, bruising, pain, and tenderness to the distal tip of the phalanx and nail. The usual x-rays of AP lateral and oblique are ordered to assess the degree of fracture and its stability. Management usually involves soft tissue repair of the nail bed and splinting and extension for 2 to 3 weeks. Use of stack or dorsal aluminum splints to immobilize the DIP joint only. This will minimize stiffness and loss of range of motion in the finger. We'll move on to joint dislocations and start with volar plate injuries. The volar plate is a fibrocartilaginous thickening of the volar joint capsule of the IP and metacarpophalangeal joints. It provides protection and stabilization and resists hyperextension. The volar plates are disrupted in dislocations and hyperextension injuries. Differential would include intra-articular fracture, dislocation, and sprains of the IP and MCP joints. There will be pain, swelling, and deformity of the joint. In complex dislocations, one will often see skin dimpling. In imaging, you should request true laterals as well as AP and obliques for detection of intra-articular avulsion or chip fractures. Joint space widening may indicate interposition of volar plate in the joint. The management involves reduction of the dislocation. Prior to reduction, digital neurovascular status should be assessed. Sometimes anesthesia is required for prolonged dislocations and significant muscle spasm. The dislocations are classified into simple, which do not involve interposition of tissue in the joint and can be treated with closed reduction, versus complex dislocations which have interposition of volar plate or sesamoids in the joint and may require open reduction. If the dislocation is difficult to reduce, or if there's a resistance to full pain-free range of motion post-reduction, then possible surgical reduction is required. PIP joint dislocations are the most common finger dislocations and can be open or closed. They're usually dislocated dorsally and involve the middle phalanx dislocated dorsally on the proximal phalanx. Volar dislocation is possible but much less common. This usually results in disruption or injury to the volar plate. DIP joint dislocations are rare and treated with inline longitudinal traction and extension splint for 2 weeks. PIP joint dislocations usually result from hyperextension or axial load injuries. Differential will include intra-articular fracture, dislocation, or sprain of the IP joint. The investigations and management would be similar to volar plate injuries, as discussed before. Of note, if the PIP joint is stable post-reduction, then buddy splinting is sufficient for 3 to 4 days. Otherwise, the PIP joint is splinted at 30 degrees flexion for 2 weeks, but with active motion for 5 minutes 4 times a day. The majority of surgeons will recommend immediate protected return to play, but there is disagreement on unprotected return to play, with about 40% suggesting after 4 to 8 weeks. MCPJ dislocations are slightly different, as the volar plates are structurally modified. They are attached down to the transverse metacarpal ligament, which stabilizes the metacarpal heads and prevents splaying. They also have connections to the periarticular surface of the proximal phalanx via the check rein ligaments. Sagittal bands also connect the extensor digitorum tendon and extensor expansion, connect to the extensor digitorum tendon and extensor expansion, and help stabilize the volar plate over the metacarpal heads. Mechanism usually results from hyperextension injury, resulting in dorsal dislocation of the proximal phalanx and buttonholing of the metacarpal head between the intrinsic hand muscles and the flexor pollicis longus tendon. In complex dislocations, the volar plate or sesamoids will interpose in the joint. Differential diagnosis would include fractures around the joint and Kaplan lesions, which are rare and most common in the index finger, which result in an irreducible complex dorsal dislocation as the metacarpal head buttonholes into the palm. The reduction of the metacarpal phalangeal joint dislocations is different than the other IP joint dislocations, than the PIP joint dislocations. Direct pressure is applied to the proximal phalanx with the wrist held in flexion to reduce tension in the intrinsic and extrinsic flexors. You want to avoid longitudinal traction and hyperextension at the metacarpal phalangeal joint, as this may cause interposition of the volar plate. Complex dislocations usually require open reduction. The joint is generally stable post-reduction and is placed in a plaster splint with the MCPJ in flexion for 10 to 14 days, followed by early range of motion. The next condition is first CMCJ Osteoarthritis. This is a traumatic or degenerative osteoarthritis of the first carpal metacarpal joint of the hand at the base of the thumb. It's secondary to previous trauma or repetitive use or injury. Differential diagnosis would include de Quervain's, sinusonovitis, and radial carpal injury. There is pain with use, and the patients will often note an axial compression, that in axial compression and movement, they may notice a grinding sensation. The deformity of the hand is described as a adducted stance with a knob at the base of the thumb, and adduction of the metacarpal and hyperextension of the MCPJ. Assessment of the joint degeneration and deformity can be accomplished with x-rays, the usual x-ray views. Management involves pain management with acetaminophen, anti-inflammatories, both topical and oral, as well as intra-articular corticosteroid injections. Joint stabilization can be provided with splints, which are static or dynamic, and soft tissue treatments can be provided by a physiotherapist or hand therapist. If these conservative measures don't help, then referral can be made to a hand surgeon.